So how do we measure the impact of value-based insurance design? If you remember, we started out by trying to figure out ways to get more people to use services that we know of evidence of improved health. So we focused cost-sharing reductions on those high-value care. There have been lots of studies now showing that if you make people pay less for something, they buy more of it. But there's only a few studies that actually show if you take more high-value prescription drugs, if you use more preventive services, if you use more high-value visits, that it actually translate into the ultimate goal for us, not these process measures, but actually outcomes. We'd like to think that the studies would show very clearly that the processes improve, that people do more of the things they should, will translate into better individual and population health. But we've not been studying these things long enough to show across the board that value-based insurance design directly improves patient-centered outcomes, although there are some studies that infer that, and hopefully many short-term studies that'll be extended longer that will definitively answer that question. But I'd like to think that if more people took their insulin, if more people took their HIV drugs, took their drugs to manage their heart disease, because these interventions have been proven to improve actual patient-centered outcomes, that the extension of the VBID idea that more people would take these high-value services would actually translate into what our ultimate goal is for better health of Americans and individuals.